Welcome again to our monthly lunchtime webinars. Really good to see you all. So, today we're joined by Sue Alcott, and she's going to let us know about promoting wellbeing in neonatal maternity care. So if I give Sue a quick introduction now, and then I have one slide to show you, and then it's all over to Sue to tell you everything she wants to say. So Sue is an experienced midwife, neonatal nurse and counsellor. She's got over 25 therapeutic experience. Her role now is as a neonatal health and wellbeing support counsellor. And she offers support and advice and appropriate signposting for parents, families and staff on the neonatal unit and community outreach service. She's been working with Down Syndrome UK well, I think we've been in contact with you for 5 years, but you've been helping us the last 3 years, providing individual and group support for any of our parents that feel they need a bit of counselling. So she's going to discuss how best to promote maternal wellbeing. So it's going to be a really, really interesting webinar today. So thank you very much for coming today, Sue. So I'm just going to quickly, before I share Sue's slides, I'm just going to tell you where this kind of came about. With the research that we've been doing at Down Syndrome UK, we've done 2 lots of research. Well, one's already been published. This is hot off the press, this one. So we've done surveys. This one's survey of women who had baby in the last 2 years to see how their mental health was. We hear that of quite a few negative experiences, so we asked this as part of our survey, and we found actually that 37% of women that we surveyed said that the attitudes of the healthcare professionals had a negative impact on their mental well-being. In terms of whether women thought they had sufficient mental well-being support, very few said that they had got sufficient mental wellbeing support, which reduced quite significantly in the postnatal period. And if you compare that to the general population as part of the Quality Care Commission report of last year, which was 85%, so there's quite a disparity there. So if I stop sharing my screen of my slides, hopefully, and hold on, and start sharing. Probably didn't need to stop sharing my screen there, did I? And share Sue's slides. Hold on. There we go. And there we are. Hold on. And away we go. Sorry, everybody. This is because I've been put in charge of sharing slides. And I'm a bit of a technophobe. There you go. So these are Sue's slides. Hopefully you can see them, and hopefully we'll have time for questions at the end. So over to you, Sue.
Okay. Good morning. I think it's nearly afternoon though now, isn't it? So just hi to everybody. As Lou said, my background is I'm a midwife by trade, also a neonatal nurse. But for the last 25 years, in addition to my work at the University Hospital in Coventry, I have worked as a counsellor in various areas. Really, I was the bereavement midwife for 12 years at the hospital, and I also work for Relate, and obviously the work I do with PADS. I've been doing that for around 5 years now, as Lou said. My current role on the neonatal unit is the health and wellbeing perinatal mental health counsellor. So I work alongside a clinical psychologist and an assistant clinical psychologist, and we work with both families and staff. It's a fairly new role, but obviously it's been very well received because lots of reports do state that each hospital, particularly neonatal units, should have somebody there on tap really for providing mental health support, because it's very obvious really by the fact that if somebody's had a baby on the neonatal unit that's sick or premature or both, that there's a lot of there's a lot of areas in which we can support. So for a lot of you, some of this might be more of a refresher, so I apologise for that. But actually, in many ways, it's not an apology, because I do think we all need to be keeping on top of what's going on. There's a lot of policy change. The NHS is ploughing a lot of money into mental health, and I do talk about that a little bit as we go along. So some of it will be refreshers, some of it will be quite new information, but I will also be talking about how we can help people with mental health issues, how we can identify them, how we can offer the right tailored support to families and individuals. And again, looking at new policies and protocols. I'll be looking at it from a whole family approach because I think that's really important. I will be touching on the support that we offer to dads, and there's some statistics around mental health and dads and postnatal depression, which is a real thing. So we'll be looking at that as well. And I'll also be looking at some new approaches in terms of counselling therapies. I won't be going into a lot of detail because obviously that would take too long, but I'll be looking at trauma-focused approaches, which is very relevant to the families that I'm involved with, and also compassionate focused, which is a fairly new type of therapy, but is working very well with families. So just to kick off, what I'm going to do is look at the terminology and definitions that we use. Oh, just to say as well, if anybody has any questions, we will have time at the end, but if people want to use the chat box, please feel free. So perinatal mental health, this is defined as mental health in the period from conception to around 1 year following birth. Now you'll notice I've put 1 year in red, and that's because currently there's quite a lot of research going on around the fact that the general consensus is that actually it should be beyond a year, and that's to do with child development. But generally speaking, it's around a year following birth. I'm also going to be looking a little bit about infant mental health, and again, not too much because it would just take far too long. But it really is important because it's obviously very closely linked to maternal and paternal mental health. And so infant mental health is largely the social and emotional well-being and development of children in the early years of their life. Again, we at the moment say around a year. Children, as we know, need secure, responsive and relationships to thrive. And it's the parents' responses which directly shape how these experiences and emotions evolve, and how babies and children learn to regulate and express their own emotions. So really, it's these early relationships that set the template for how babies develop. And there is a direct correlation, as I say, between the mental health of the family and babies and infants. Again, I've got some statistics here that many of you will be familiar with. And what we know is 1 in 4 women are affected by perinatal mental health problems. That figure probably is not totally accurate because obviously these statistics are reported statistics. So there are probably lots of people who suffer mental health issues around the perinatal time that are not reported on. So people that don't say anything. We know there is still, despite all the work going on, there is still stigma around perinatal mental health. Well, any mental health really, but as we're talking about this today, there is still definitely a stigma. And people worry that, again, if I give you an example, the way I approach families on the neonatal unit is very important, because if I go up to somebody and say, I think you need counselling for mental health, then that is already going to put up a barrier, because people still have the old-fashioned view that if we think they're not coping or they're struggling in any way, that their children may be taken off them. So that is a real thing to have to consider. Maternal suicide, shockingly, is still the leading cause of death of women over the perinatal period. And I've got some more detailed statistics on that from Embrace as we go along this morning. It's the most common and serious health problem that women can experience in the perinatal period. And again, I mentioned that we'll be talking about dads. Approximately 10% of fathers will experience perinatal illness. Roughly 25 to 50% of fathers will experience anxiety and depression. And that increases if the mother also has perinatal mental health illness. So again, looking at the baby and the infant, the impact for the fetus and the infant and child, having a parent with mental health is demonstrated in poorer outcomes, and there is a much increased risk. However, you'll notice I've underlined here that it's not inevitably negative, because obviously if we get in there quickly at the right time, and if we support parents in the correct way, and we refer appropriate to the right agencies, then obviously this wouldn't be the case. So I don't want you to all think that obviously every parent that has mental health, there's going to be a negative effect on their child. We know it can happen, but it's not, as I say, definite. So it is essential, though, that we're proactive in intervening at the earliest opportunity. And that can often be preconceptually. I'm going to talk a little bit about costs, because obviously everything revolves around money, our services, commissioning, everything really, unfortunately, in many ways. But we do know that there is a huge cost around perinatal mental health. And this is specifically around births in the UK. So as you can see from the pie chart there, you know, there's a huge cost. There is a huge cost to society. So in health and social care, other public sectors, so that would be things like education, and of course the wider society. Narrowing this down a little bit in terms of how this relates to a mother and her baby, you know, it's around 28% related to the mother, and a big 72% relating to the child. So we need to look at the cost and how we can make improvements. And the cost, as you can see from the slide here, the cost of the public sector of perinatal mental health problems is 5 times that of the cost of improving services. So again, when we're looking at policy and guidelines and government documents and who commissions, who pays for things, we need to be really looking much more closely at this, because it's much more cost effective to prevent the issues in the first place. As we're talking about policy and research, this is just literally a very quick snapshot really of the types of documents that we work with that really help us shape the services, provide new services, and look at what's going on. You'll notice Embrace is on there. I do talk a little bit about that because that is just looking specifically at maternal factors, specifically around, sorry, lost my words here, specifically around maternal death. And you'll all be familiar with the Saving Lives reports. And also it looks at stillbirth and neonatal death rates. And it looks at these things from a confidential inquiry perspective, and surveillance of statistics across the UK, and looks specifically about the correlation between these statistics and mental health. So very pertinent to what we're talking about today. So as I said, you know, mental health is high on the agenda. We're much, much better at looking at mental health, talking about it, monitoring it, supporting it. As I say, there's still a stigma. It's not anywhere near like it was, say, 20 years ago. There's still a lot of work to be done. There's still a lot of ways which we can move forward. But the NHS 10-year plan specifically looked at improving mental health across the board, really. It looked specifically at expanding specialist mental health care for mothers during pregnancy and following pregnancy. And there was also now things put in place for when people are wanting advice about getting pregnant, so even before pregnancy occurs. So, for example, women who are suffering with any diagnosed mental health problems and wanting to get pregnant, it's really important that they have support and signposting to the correct care and service. Medication, for example, if somebody suddenly stops taking their medication for a diagnosed mental health problem, this could be really catastrophic for them. But also, we need to look at the effects of medication on an unborn fetus. So there is normally always an alternative medication that can be used. But it's important that this is why we talk to families and we talk to women, and we ensure that they don't feel that stigma, so they can have those open conversations about what they're going to do if they're planning to have a family. We need to ensure also that there is timely access to appropriate evidence-based perinatal mental health care. And as I say, there is a lot of work ongoing around this area. And so, you know, it's much more, as I say, it's much more there on our dashboard in terms of care and what we can do. Early identification and diagnosis is imperative for us to get the right treatment for families and to make sure that they're involved in their care planning. We need to increase awareness around perinatal and maternal and infant mental health. And as I say, this is just a snapshot today, it really is. But it's you guys, it's the health professionals out there that need to be doing that. We need to have increased awareness. We need to be able to have those conversations that may feel difficult, but it's important that we have them. And we need to develop much more robust pathways of care. And as I say, that includes from preconception right through to postnatal. So I'm going to talk to you now about the different types of depression in and around pregnancy. Antenatal depression, again, there's not much about this really, but we know it's a very real thing, and it can affect more than around 1 in 10 women, and it's possibly, actually, the statistics probably isn't correct, it's probably more like 1 in 5. Depression and general anxiety disorder is probably the most common thing that we tend to see, and it's absolutely a precursor for postnatal depression. There is much more of an increased risk if we know that a woman is suffering with antenatal depression. We don't really know why this happens, but it's probably to do with hormone changes, genetics, and of course, it will be environmental. So it will depend a lot on the type of support a mum has. So, you know, there is, as I say, there's still work going on around this, but we do know it's a very real thing. And it's approximate, again, because I think probably the figure is not accurate and it's probably much higher than we realise, but around 20% of women don't receive the appropriate treatment antenatally. So what can we say is the impact of adverse pre-mental health? Well, obviously, it's been shown to be associated with poor outcomes. That would seem obvious, but that would be in the short term and the long term. And children of women who experience adverse pre-mental health during pregnancy have a greater risk of adverse neurodevelopmental, physical, social, and emotional and behavioural outcomes. And again, I want to just stress here that this isn't inevitable. It doesn't mean it's definitely going to happen, because I would hate to think that people think that because so many people do have mental health. We all have mental health, in fact, don't we? Sometimes it's good, sometimes it's not so good. And a lot of it can be circumstantial, depend on what's happening to you at that given time. So it is important to know there is a great opportunity to reduce and even prevent the effects, so that, you know, obviously these children will be fine. Perinatal or postnatal depression, however you want to name it, again, we do know about this. We know about baby blues, and we know that I would say the majority of people having had a baby will have what we call the baby blues. It's quite mild, transient, and doesn't really last very long. And we know that it can happen to between 30 to 80%, again, probably near the 80% mark of new mothers in the first few days. Again, it's linked usually quite exclusively with hormones and just the fact that, you know, becoming a new parent can be quite a period of adjustment. So although we need to be aware of that, it's something that, as I say, is transient and will pass. And we just need to make sure we're supportive during that period. However, postnatal depression is a more persistent low mood, and it can be of varying severity and duration. And it's often missed, because this is the time at which people feel, I'm not coping, but I don't want to say anything, or it's just the baby blues. And so a lot of the time it's missed. Once the midwife has completed her checks and discharged mum, obviously, in terms of universal service, health visiting and GPs take over with the care as being the main professional. And we know people are stretched to the limit. We know there are not enough health visitors, there are not enough midwives. So again, sometimes these signs are missed, or mums become really good at covering it up because, again, of that stigma that we've talked about. The incidence of postnatal depression is around 10 to 15%. Again, How accurate that is, I don't know, because these are cases that are reported. And it is the most common complication of pregnancy. And 40% of women are likely to experience subsequent postnatal or a non-postnatal relapse if they've already had it initially. And also, new research is indicating currently that women who have persistent postnatal depression may have depressive symptoms for up to 11 years after childbirth. That's a long time. So again, when we're thinking about that relationship between mum and baby and the family, it can have an adverse effect on children growing up. So the risk factors, there are quite a lot of these, as you can imagine. And I think if we looked at these really closely, any of us could somewhere fit into some of these slots. So previous history of mental illness, family history of mental illness, childhood trauma, poor parenting, antenatal depression and anxiety, major life events and stressors, so any traumatic event that may have happened, and we do touch on that a little bit as well later on. Low social support or support from partner, or some women don't have partners. You know, they may not geographically live near their families. Years ago, we lived in big extended families, didn't we, where there were grandmas and aunties that could help. That's no longer the case. Any domestic abuse in the family, substance misuse, relationship problems, again, major life events, as we've touched on. And this one's quite interesting because it's very, the statistics and the research shows that if a mum has lost her own mother, that bond and that connection she has maternally with her own mother when she has a baby is lost. So that can be quite difficult. So I say and because, like I say, there's a big list. Birth trauma, any babies with special needs or who have been on a neonatal unit, or separated from their mum at all. Teenage mothers and fathers, an insecure environment, housing. And again, you know, we're having a housing crisis, aren't we, particularly in the UK. So, you know, that can be a real problem. Financial worries. You know, I needn't say how things are at the moment. We're in a recession. You know, energy bills, all those sorts of things that we're reading about all the time that some of us ourselves might be affected by. You know, it's a major issue for families. Natural disasters, earthquakes. I mean, obviously, touch wood, we don't get that happening in this country very often, but we can be affected by it from other countries, and we know that it happens. And war and conflict, and we need to just look at the news to know that that's happening to people globally. Any long-standing vulnerabilities, I put personality vulnerabilities there, but that's, you know, again, if somebody has a diagnosis of a mental health problem. I've put COVID-19 because that links a little bit with some of the embrace work that went on. So again, you know, that was a really difficult people. And we're still actually just in the recovery phase of COVID. So everything that happened is still impacting on some families. I'm going to touch on postpartum psychosis. It's rare, but when it happens, you know, it's really a serious issue. One of the things about postpartum psychosis is that it's often not picked up because, again, it's hidden well, and again, because of that stigma around it. It only affects 1 in 2, so in around 1 to 2, 1,000 mothers. So as I say, it is rare, but it does usually require immediate hospitalisation. It can be rapid onset, but as I say, it can take several weeks to detect. And it's more common in women who have known bipolar disorder. That's one of the things that, you know, is very obvious when we look at the history. There is a risk increased in a family history of postpartum psychosis in somebody who has a relative, a first-degree relative. And the rate of postpartum psychosis is almost double that of women with bipolar, but without a family history. So although from this you think, well, you know, that is quite rare, it's the severity of the condition which is really important. Again, some of these symptoms on this list, you know, could be linked with other things in terms of depression, low mood. But it's things like the hallucinations and delusions, which would be really something that would be a red flag if you were speaking to somebody. Quite bizarre behaviour sometimes, confusion, lack of insight into how they're feeling and the things that they're doing. And there's a huge risk to the mother, first of all, but also there can be a risk to the infant. I wanted to talk about dads because I think they get a bit of a rough deal sometimes. You'll all know yourselves working with families that the first question is to the mum, how are you doing? How are you coping? And dads will often say, you know, what about me? And so it's really important that we're aware of this. And the work I do with dads, we've had a couple of dads groups. Well, actually, there was only one because we've found it really difficult to get dads together to speak. Again, you know, that just could be, you know, the way dads are brought up. Is there still that, you know, oh, they need to be strong, they need to be the ones, you know, keeping everything together. However, I will say that I've spoken to quite a number of dads on a one-to-one basis. So whether again it's around feeling safer doing that rather than a group, but I do feel quite strongly that, you know, we need to be supporting dads, and again, you know, as we go on, as you can see from this, yeah, it's fine to carry on. We know now that dads also can suffer from antenatal and postnatal depression. And this is only really, the research is quite robust, and it's been really the last decade that this has all come to light. So, for example, if you look at that antenatal depression, 11 to 12% of fathers can get that, and 8 to 26. Again, I would say it's probably near the 26% can actually get postnatal depression. So it is important. It is important that we know this and that we're aware of this. And that's why I was saying earlier, it's important when we're looking at mental health, we need to be incorporating the whole family. Often dads are the main support for mums. So again, if they're struggling, that's going to be really difficult. And what we do know is there's a huge rise, around 50% increase in postnatal depression amongst dads if their partner is also struggling. So again, it's really important that we're aware of this and we know to signpost to the right support. This is just really a list of what happens. So when men get depressed in the postpartum period, it's usually like a general anxiety disorder that's obvious. The factors that will increase the risk of men getting perinatal depression are their age. What we find is younger dads tend to really struggle. Low income. Again, a lot of these things on the list will affect anybody, but just in terms of the research that's done, this is the sort of things that have come up. Difficulty with the actual relationship. And again, sometimes, you know, it is a struggle. And particularly we find with young parents, you know, it may be that they just haven't known each other that long. I know that can be the case for any age parent, but we do find this is quite common. And the timing of the pregnancy, you know, maybe the pregnancy wasn't planned, maybe there are financial worries. So again, if the family or the couple have poor social and emotional support, we know that is very evident that the risk of depression in dads will increase. The important thing to note that actually, you know, if we do find that dads are suffering from depression, it's absolutely associated with higher levels of emotional and behavioural problems in children around the age of, you know, 3 to 5 years of age. And what's interesting, it seems to be particularly in boys. We don't really know why that is, but that's what the evidence shows. Children in a home with both mum and dad who have depression, anxiety, or any other diagnosed mental health illness are also at an increased rate of poor development outcomes. I wanted to touch on this a little bit because particularly the suicide bit is just, you know, it's really sad that, as I said earlier, you know, with Embrace and so on and the work that they do, that it's, you know, suicide is still quite high amongst women in the perinatal period. Pregnancy and childbirth, as we all know, is a huge time of adjustment. And if somebody doesn't have the abilities to be able to cope with that adjustment, it can be really hugely difficult for them. And all the things we've discussed so far, all the reasons why people might feel that they're not coping with mental health, poor support, financial worries, isolation, all of that, that will just make things worse. And we know that it's a huge risk for some mums. Self-harm I've mentioned because it's not the same as suicide, but women are much more at a greater risk of self-harm, and particularly if they have done that before. The important thing about this slide is, and I've put it in red, is that it's not wrong to ask about how people are feeling in relation to suicide and self-harm. I think people sometimes worry that, oh, if I mention it, it's going to put the idea into their head. Now, we know for a fact that that isn't the case. But if it is something they're thinking about, it's really important that we know so that we can develop a safety plan with that person. Because actually, if somebody is seriously thinking about taking their own life, there's not always a lot we can do if they've got to that stage. But we need to be able to sort of support and help with that. And we need to be able to unpick what it is that's causing those thoughts. So I think it is always really important to ask that question and not be afraid to. Okay, so here we go. This is the Embrace slide that I was talking to you about. This is the most recent report. The current work they're doing isn't yet published. But this was just from the key messages that came out of the report. And again, it's very sad to say that maternal suicide does remain the leading direct cause of death in the first year after pregnancy. And a quarter of all deaths of women during pregnancy or up to a year after were from mental health related causes. The other thing to note here is the outcomes for women are not equal. What I mean by that, depending on what ethnic minority group you might be from, depending on your socioeconomic group, the outcome is not equal. I felt I needed to mention safeguarding because we've been talking about, quite severe mental health issues. We're talking about suicide and self-harm. And we know we've already talked about the impact that all these things can have on the children within a family. But it doesn't mean that, we can't make assumptions that people who have mental health issues are going to be bad parents. That is not the case at all. And I do feel quite strongly about this because I think sometimes people are labelled and we do make assumptions that we should not do. But it is important to know that obviously there is a higher risk. If the family are struggling, this may impact on the children, as we've already discussed. But what we need to do when we're looking at safeguarding, when we're making assessments and we're thinking of perhaps making referrals, is looking particularly at what services can be involved to help, but also to look at what's going well. So if there are strong relationships between the parents and children, and if parents have good insight into what's happening to them, and if they're accessing support and care, and that what's their abilities in order to respond to the challenges that they're faced. In other words, what resilience do they have, and what support do they have? So what we need to do as health professionals is to look at this as a whole. Again, look at it from a family-focused approach. Look at work within our sphere of competence and seek supervision if we need it, but record and document accurately and timely. And communication, I would say, is the biggest thing here. Like with most things, we need to be communicating accurately with the families. I'm also going to touch on equality and diversity, and again, this links with Embrace and reports and documentation that we have. We know that obviously this does impact on social and ethnic inequalities and those that have multiple disadvantages. And this again was highlighted in the most recent report. Again, talking about COVID, we know this had a huge impact on health outcomes. And if I give you an example, so during COVID, between 2019 and 2021, there were approximately 33 maternal deaths and that was put down to COVID infection. But of those 33, 14 were Asian women and 5 were Black women. So again, it's important that we're aware of this and we address the systematic issues of culture and structural biases. And we need to make sure that, you know, these people are getting the right support as well, in order to prevent maternal death and disease. So our families who identify as being from minority ethnic groups, this is just a list really. So we've got refugee families recently come over to the UK. Often these women will say they feel totally isolated. It's an unfamiliar environment. The language is unfamiliar. Often they're put into poor social housing. There are other cultural issues that we don't understand and, you know, don't claim to understand, but we know that's there. Unemployment, a lack of information. And again, I go back to communication because I just think this is pivotal to everything really that we do. So if there's poor communication, these women and their families are unable to access services. Again, just a little snapshot really from the Embrace reports, just highlighting. And as you can see, if you look at these slides, there is such a big disparity between, you know, different groups within our society in terms of deprivation. So, you know, it's sad really, but this is where a lot of the work needs to be done as well, I feel. So the role of the health professional, you know, as I said, it's hugely difficult. You know, we're working in difficult circumstances. We know most areas are short of staff. People are really finding it a struggle. I know working in the hospital, that's the case, but I also know, having worked in the community and obviously with my colleagues in the community, that this is also very much the case. And it's hard. I mean, I remember back in the day, you know, the midwife would come out to you pretty much every day and see you. She'd chat to you, you'd get to know her, you'd build up a rapport. You know, that doesn't always happen anymore. You know, you might see your midwife on perhaps a couple of days after discharge, and then, you know, when the baby's blood spot test needs doing, and then, you know, and then you're discharged. So there isn't always time to really get to know that family and get to know that mum. And as I say, because of the stigma, a lot of mums will put on a bit of a front. They'll sort of want to let you know that they are really coping, that it's okay, when really it isn't. Of course, again, going back to COVID, you know, that was just such an awful time. People just didn't see anybody. You know, how can you really tell how a mum's coping, say, looking on a screen or even from a phone call? And that wasn't the health visitor's fault or the midwife's fault. That was the way that was the situation we were in. But it will be very interesting to see the impact of that on families and child development going forward. It's a bit early to tell at the moment, but I do know some of the work that's been done isn't showing the most positive outcomes. So how do we help as health professionals? How do we do that? We need to recognise and identify mental health. We need to, as I say, have those uncomfortable conversations. And we need to ensure that the right help is available. And that help needs to be absolutely individualised and tailored, because everybody is different and everybody will respond to their situations differently. So it's not a one size fits all. But we will only know that by, as I say, having that relationship and forming that sort of bond with people and ensure with the people we're working with, so that we can ensure that people feel in a safe place to have those discussions. As I've already talked about very briefly, we need to be aware of cultural differences and needs. You know, I hear people sometimes saying, well, I treat everybody the same. Well, actually, people don't need to be treated the same, because people have different needs. So actually, we shouldn't be treating people the same. We need to also ensure, and again, as I've said this morning with the previous slides, referrals need to be timely. We need to capture things very quickly. We don't wait until things are, you know, getting to a very, very difficult point. And again, it needs to be appropriate. So it needs to be appropriate for that person. acknowledging the stigma, we've talked a lot about that, and looking at the different treatment choices and enabling families to make informed choices. So again, not just saying, well, we'll do this with you or prescribe this for you. We need families, particularly mums, to be on board with care planning and what is going to be best for them. Medication we have touched on. We need to discuss the risks of benefit, because again, we do know that, say, if somebody's pregnant and they're on certain medication, it may not be ideal, but we need to look at what the alternatives are. And postnatally as well, we need to look at what's best for that mum. Will it affect breastfeeding or won't it? Sometimes what happens is a mum will become pregnant and think, I'm just going to stop the medication. That's not great for her at all, but she may be worried about having that discussion. So again, we need to offer that supportive environment for her to do that. We need to offer self-help resources to families, and signposting. Not everybody will need formal input. In other words, not everyone needs formal counselling or the involvement of a psychologist. If I give you the example of the work I do with PADS, the majority of women that I speak to and dads, all they need is somebody to listen to them. They need to be able to vent how they're feeling. They don't particularly need anything more formal than that. As I say, a listening ear, somebody just to show empathy and compassion towards them. So it's not rocket science, and it's quite easy to do. I will say, obviously, some people will need signposting to something more formal and structured. But to give you an example, I've been working with PADS for 5 years, and so seen lots and lots of families. I wouldn't be able to say how many totally, because there's a lot. But I probably can count on one hand the number of mums that I've had to actually signpost to something much more formal for their mental health. So I think it just shows that actually having that support is so important. Talking therapies is the main, I would say, the main avenue that we go down in terms of support versus medication. Sometimes it's people will need both. But yeah, talking therapies is the main thing. And there's lots of different talking therapies, and I do touch on that slightly in a few minutes. But also encouraging self-care and well-being. And we're big on well-being now, aren't we? And a lot of organisations are taking that on board. So HR departments are looking at well-being for staff. I could talk all day about that because I think that's also really important. But it is about thinking about that as well and how we promote that. In the beginning, I did say to you that I look at all of this from a family approach. So within the perinatal frame of mind, I think family is at the centre of all of this. Mum is usually in the very centre, but family is also around the outsides, and it's really important that we think about that. And you look at this slide, these families are all different, and that's because absolutely we are all different. Our families are all different. And that's why I bang on about the fact that, it does need to be tailored to individual need. So supporting parental emotional well-being in our practice, we've talked a lot about this. So I don't want to be too repetitive, but it is about supporting parents in that emotional and physical transition to parenthood, because those two things often go hand in hand. Encouraging healthy relationships within the family. I often say when I'm talking to people at work, I often say, don't forget about you're a couple as well. So as well as being new parents, it's trying to remember that, because that's important. Be curious, ask those questions. I know it's uncomfortable sometimes, and I know I probably, because I've been doing this a long time, I don't find it quite as uncomfortable as I did, but I have been in that place where I think I daren't ask that because it's going to be a trigger. So it is important, and it is about encouraging, if we have any concerns, just encouraging sharing those concerns and saying something like, I've noticed the last few times I've seen you that you seem a little bit low. It's opening up that conversation and not being scared to do that. And the important thing as well is obviously, again, linking it with the infant and the relationship between mother and father and child. It's encouraging the development of sensitive and reflective parent-child relationships, and that can start antenatally. Again, there's lots of research out there, isn't there, about the impact of parents' health and well-being on a baby before they're even born. We absolutely know that to be true. And it's helping parents to begin to relate to their baby as soon as they can as a little person. And it's integrating the emotional well-being, as I said, alongside the physical well-being, and how explaining how that all links. And again, adopting the whole family approach. So what services are available to our families? We've got our universal services, the GP, maternity, health visiting and social care. And then we have the NHS talking therapies, which was formerly known as IACT. So that's very widely used. And then we have secondary care, which is specialist perinatal mental health services. And those are for those families with very complex issues. And for example, we talked about postnatal psychosis. So things like we have mother and baby units. It's a bit of a postcode lottery really as to where those are and how well they are received. But those are the sorts of things that we would need in really complex cases. We also have children's mental health services. So we have young adults sometimes who are having babies themselves, who are perhaps still in those services. So for example, CAMS. But then also moving forward, if we know families are struggling and if we know there's children within families who are needing mental health input as well, these are the services that we'll be tapping into. And then we've got obviously the wider local authority services. Again, housing and social needs come into that. So treatment for mental health in pregnancy and beyond. First stop usually is the GP. Excuse me. Midwives and health visitors are high up there, aren't they, in terms of people that we're going to be seeing if we're pregnant or if we've just had a baby. And again, the treatments vary. We've talked about talking therapies. So there's things like cognitive behavioural therapy. Some of you may have heard of EMDT, which is eye movement desensitization therapy. It's a fairly new therapy, and that's used mainly for trauma and has had some extremely good results. So those are things to think about and have in the back of your mind when you're talking to families. Again, it's not always accessible everywhere at the moment. Trauma-focused therapy and compassionate-focused approaches are becoming much more popular and much more readily used amongst therapists, because we're finding that they do tend to work really well. And medication, some mums and dads will need antidepressants, and we know that. And so, you know, obviously we'd look at other things first, because not everybody wants to go down that route. And some people are quite reluctant to go down that route. But, you know, they have a place and they do work. And so if the depression is more severe and other treatments haven't worked very well, then it's really important that these women, well, and dads, as I say, are prescribed the correct medication that's safe to take either during pregnancy or breastfeeding, as we've mentioned before. And that it's not just a question of saying, okay, here you go, take this and you'll be fine. It is a question of, you know, yes, you need medication, but you also need some additional support, and we need to monitor the medication and review it regularly. I talked to you about the trauma-informed approaches, and again, I'm not going to go into great detail because it would just take far too long. But a trauma is not just, you know, something that we think about when we think about, you know, a war zone and people getting blown up, because often people think about that. It can be any situation or any event which is stressful or frightening to us as an individual. So what I might find distressing, you know, you guys might not. But also a traumatic event can happen at any age, and it can cause quite long-lasting harm. So we hear about, don't we, childhood trauma. So if a mum has had some sort of childhood trauma, having her own baby, actually, and if she feels traumatized and distressed around the birth or something that's happened, that can be a huge trigger for what's happened to her previously in her life that may or may not have been addressed. And so, again, it's knowing that everybody will have a different reaction to trauma, and the effects can be immediate. So she can suddenly feel traumatized and show signs of trauma, or it can be longer term. And again, that would link with somebody that's had a trauma in the past that's resurfaced. What helps for individuals is different, and it can change over time. So we can be doing some work with somebody that seems to be working, and then suddenly it doesn't, or something that doesn't work but then can. So it's about sort of keep reviewing what we're doing when we're working with families who are traumatized. And I like this sort of little saying here that I read quite recently. So when we're working with families who have suffered trauma, and as I say, that can be anything that has caused stress or is distressing for them. It's about changing how we word it, changing the narrative from, oh, what's wrong with you, to what has actually happened to you. Trauma will activate our threat systems, and we all have threat systems. That just means, from a very primitive brain perspective, what do we do when we're scared? So fight, flight, and freeze, you'll have all heard of that. That's what the primitive brain does. And at one time, that was just so we could run away from our predator. But now we have much, much more complex lives, and we have a much more complex brain, in fact. So our modern brain can't always cope with just fight, flight, and freeze. And that is all to do with our assumptive world, which we've known about since we were born. And it's about, how do we fit into this world, and why do things happen? And also, the big one is how we expect our life to unfold. Because when something happens to us, whether it be something in childbirth or anything at all, if it's not what we expected, that is the difficulty. So again, if I just give you the example of the work I do with PADS, when I'm speaking to a mum who's had a diagnosis of her baby having Down syndrome, and she wasn't expecting that, and it's a huge shock, it's about helping her think about that in a way that, yes, this absolutely was not what you thought was going to happen, and how she can cope with that. So she thought she was going down one path, and she's now going down another. And it's about supporting with that. Because a lot of women say to me, one of the one things that they say to me in the beginning when we first have conversations is, I imagined that when I got pregnant that I'd be walking through the park with my baby in the pram, and it was all going to be lovely, and this is not what I expected. So those hopes and dreams have been taken away. And if a mum has her baby early, that last part of her pregnancy has also been taken away from her. So I liken it a lot of the time to a bit like grieving. So, she didn't get to have her last day at work. She didn't get to have a baby shower. And she didn't get to do all that nesting that we do in those last few weeks. So that can be like a loss, and almost, as I say, like a grieving process for some mums. So again, this is just to highlight what I was talking to you about, feeling safe and vulnerable. So safety versus safeness. So this lion here has got got the primitive brain that I spoke about. He's running away from that herd who are going to attack him. So that's all he can think about in terms of safety. But this guy on the right here, he's feeling safe. So he can cope with things that are being thrown at him because he feels he's in a safe environment. So he's being supported by people around him. Compassion. This involves feeling for another. It's a precursor to empathy. And it's feeling as another. So it's not sympathy. So sympathy is something that we feel towards somebody. We might feel sorry for them and think, oh dear, that's terrible. We don't actually feel what they're feeling. We can't totally feel what somebody's feeling because we're not in their shoes, but we certainly can feel compassion and empathy. And active compassion is the desire to alleviate another one's suffering and the ability to understand it and approach it and help when somebody's suffering and distressed. So compassionate focused approaches, these are relatively new. As you can see, the year 2000, Paul Gilbert's one of the main people that's developed CFT, compassionate focused therapy. It covers a wide range of interventions that combine a number of approaches within psychology. It tends to be rooted within Buddhist traditions, and it's aimed at those people who experience high level of self-criticism and shame, which is actually thought to underline a lot of mental health conditions. And a lot of the mums that I speak to feel that. They think it's their fault somehow that something's gone wrong, and they feel shame and embarrassment. So again, this is something that will be, I think, be much more on the mental health agenda, and people will come across it a lot more. I want to talk to you now about the work with PADS, because obviously this is fantastic, and I'm really privileged and honoured to have been working for PADS for 5 years, having met Nicola at a training session that she was putting on. So since around 2000, and actually it's 2018, I've been working as a counsellor for PADS. So just this year alone, I've probably had over 100 referrals. So the referrals come basically from PADS. So people will contact PADS and they'll say they're struggling. It might be a new mum, first-time mum. It might not be. It might be somebody who's got other children. Sometimes it's within the first few weeks of the birth. Sometimes it's quite some time afterwards. So there's no criteria. Anybody is welcome to be referred. And I will speak to families on a one-to-one basis. Because it's UK-wide, it's difficult, obviously, to do face-to-face. I mean, I have people from Scotland, Wales, England, you name it, all over the country. And the telephone counselling seems to work really well. In addition to that, I run groups. So we've had groups specifically for grandparents. We've had specific bereavement groups. Again, they're on Zoom, so they're not face-to-face, but the feedback from them has also been really good. And I just tend to facilitate those. What's so nice about those groups is that people get to know each other in a short space of time, and they become a support for each other. So they'll have their own WhatsApp group. And the other thing that's really good about that is somebody will say something, and then another mum will say, oh gosh, yeah, I thought I was the only one thinking that. These forums are completely confidential. So people do, again, feel that safeness. They feel they're in a safe place to be able to discuss what they're feeling. And also, you know, a lot of the time they realise that, you know, they feel the same as everybody else going through this same journey. So dads and non-birthing partner support, say we have had one dads group, but we have struggled with that. And that's something that we are working on. Because again, I've said how important I feel that is. I've also run a couple of sibling groups. That was because there was a general feeling that people were assuming that maybe siblings didn't cope very well when their sibling was diagnosed with Down syndrome. And the idea was sort of, I think, quite strange to me, because obviously parents that I spoke to, I didn't feel that at all. And it was great because running the group really highlighted that these children don't feel negative at all. And actually, you know, they don't know any different. All they see is that's their brother and sister or sister. And, you know, that was really good. And we sort of opened it up by saying, you know, what's it like, you know, having a little brother or a little sister who has Down syndrome? And there was never, as I say, anything negative at all. In fact, it was quite funny because one young lad said, oh, he really annoys me because he's always taking my PlayStation control. So it's things like that, which any other sibling group would be, you know, discussing. So that was a really, I felt really valid group to run, and it was great. I offer a wide range of approaches to parents because, again, I tailor it to what they need individually. And as I said earlier, quite often, I don't need to do counselling as such. It's great that I've got the counselling skills and I know what to look out for, and I know how to signpost if I need to. But most of the time, people need to know that what they're going through will get easier. There is light at the end of the tunnel, and that there is lots of support out there for them, and they just need a listening ear. But as I said, I do need to sometimes signpost, and I will do that to the most appropriate agency. So I'd just like to thank you for listening today. And if there's any questions at all, please feel free.